I am GISELA Foss. I am a research and advocacy lead for Abortion Data. It's a global organization. I'm based in Brazil. I am also an associate with Women in Global Health Brazil. And I am a lawyer and a public health specialist, and I've been working with sexual and reproductive rights for 7 years now. And I'm honored to be the moderator of this panel. We are going to talk about SDGs. So mainly SDG 3 and 5 for gender equity and good health and well-being, but all these SDGs, they are interconnected and we won't advance without gender equality. So being mindful how they are connected and crucial to active sustainable development across the board. And women play a vital role in building resilient societies, right? And it's very important to acknowledge their role in healthcare. So I'm here with these brilliant women, and I'm gonna go to the really hard part, that is introducing them, because they have really long bios, so I had to select carefully. I'm here with Dr. AGATA BLOSWICK, who brings 2 decades of healthcare industry experience and has held leadership roles in private and public pharmaceutical companies, including Pfizer, IQVA, LabCorp, and Fortrea, overseeing up to 60 countries and 2,400 employees. Her career expertise includes end-to-end delivery of the drug development process, as well as global geographic healthcare impact. She has taught research ethics at Yale University and focused her interests on the intersection of healthcare and climate change. Thank you for being here. I'm here also with Dr. OLAYINKA BADMUS, who is a public health professional with expertise in social and behavioral change, and focus on gender programming. She serves as the Deputy Project Director for Risk Communication and Community Engagement at Johns Hopkins Center for Communication Programs under the Breakthrough Action Nigeria project. In her role, she applies the gender lens to health interventions, particularly in addressing cultural and social norms that perpetuate gender inequalities. Dr. BADMUS has led the development of impactful initiatives such as Women's Empowerment Group, Haske Mata, which supports women in northern Nigeria by fostering safe spaces for learning about reproductive and mental health, resulting in 417 groups and more than $250,000 generated in funds for business and health purposes. Thank you so much for being here. Dr. Suzanne MAMBO is a public health professional with over 15 years of experience, currently serving as a lecturer and program leader at Jomo Kenya University of Agriculture and Technology. She holds a PhD in Health Systems Management and an MPH and a bachelor's in environmental health. Dr. MAMBO has extensive experience in academia, research in both governmental and non-governmental sectors. She has collaborated with public and private institutions, including Kenya's Ministry of Health and CDC EU-funded projects. In addition to her academic role, she leads strategic initiatives for women's leadership and economic empowerment as Director of Women Advancement for Economic and Leadership Empowerment Foundation, and serves as the Executive Board of Women in Global Health Kenya. Thank you for being here. And Dr. ANNICK, SIDIBE, she's from Women in Global Health from Burkina Faso, and is a medical doctor and public health specialist with over a decade of experience in health systems strengthening, global health security, and immunization in low and middle income countries. She currently serves as Global Health Security Technical Advisor at JPIGO, supporting outbreak prevention, detection, and responses across Africa, Asia, and Latin America. He's also the Special Advisor of the Gavi Francophone and Lusophone Africa Constituency, and a member of the Women Global Health Board of Directors, and Deputy Board Chair of the Global Health Security Agenda Consortium. So yes, let's jump right into it. Yeah, round of applause. So we want to address two topics today, just to bring this to a very concrete conversation. One of them is the Great Resignation, is the exacerbated burnout and pandemic-related issues that has added pressures to women working in healthcare sector, and the global south to north exodus of healthcare workers, so people who are immigrating to the global north as healthcare workers just seeking better opportunities. And I will start with Dr. AGATA. We are not on track to meet SDG 5 or 3 and by 2030, right? We're just, 5 years and still have a long way to go. So from your perspective, what are the biggest barriers facing women, particularly in healthcare, to achieving these goals?
So I'll start by saying that if we look at healthcare as a continuum, the inequality starts at the very beginning, at the time of the research and development. So it impacts the inequality in leadership positions, impacts what diseases we research, it impacts where we research them, and then that perpetuates that inequality moving forward. So just giving you an example, there's only 3 companies that are pharmaceutical large companies that have women CEOs in the world. And those companies are known for researching a lot of women health issues. All the other ones aren't necessarily. And when we think about that gender inequality in what diseases we research, and therefore what diseases we end up curing, there's another challenge of where we do this. So the leadership is also concentrated in very few geographic spots. So we end up oversaturating certain markets with clinical research, meaning those patients have more options for their cancer treatments, for their diabetes treatments, and so on. And they can effectively go from one study to another and continuing and prolonging and improving their health outcomes. While there are countries with big populations that never get the clinical trials, or they don't get enough clinical trials, and that then impacts what are the patient's health outcomes. So I'll give you an example of pre and post pandemic. We have seen a huge shift of where we do clinical trials. There's more trials being done in the US, there's more trials done in China, there's more trials done in Western Europe, and there's less and less trials done in places like the rest of Asia, Eastern Central Europe, Africa. So we see that shift that's happening. You mentioned the healthcare workers shift. We see the patient opportunities in research and development also shifting geographically. So there's 2 elements here is the leadership. Who are the leaders that then decide where are they located? Because that then impacts how comfortable they are doing clinical research in certain countries and how uncomfortable they might be in taking the study to certain location. And that then impacts later on the patient outcomes and options for care. So that's one element of that. What I also want to address is the inequalities in the healthcare workforce itself. So we all think we have 24 hours, and I don't think that's true, because we know that women have significantly more unpaid work that they need to deliver at home. And that then impacts how much work and effort they can deliver into their jobs, and how they climb that corporate ladder, and then take those C-level positions in corporations that is directly impacted by how much time they can spend on networking, building those connections, and building their career. So I'll just have a few data points for you. So it's not just about how much more they do than their husbands at home. I come from Poland, so in Poland, average woman does 5 hours of unpaid work at home every day. And that's twice as much as their husbands or partners. But a woman in the US spends an hour less, and a woman in India spends an hour more. So when we think about the diversity, I don't think it's a male versus female, right? A woman versus a woman. It's also a geographic distribution of that diversity, because as I said earlier, it then will impact our decisions of where we place the research, what we research, what diseases we research, and what are the outcomes of the patients from the communities that we represent as leaders and as companies.
You touched a little bit on pre and post pandemic idea, and I wanted to know, how has the pandemic deepened inequalities in women's health and leadership in the global health sector? How it impact practically in this sector?
So working in pharmaceutical and pharmaceutical-related companies for the last years, I have seen that we have been observing a lot of healthcare professionals who day-to-day work with patients, like nurses, study coordinators, even doctors, women doctors, resign from their care jobs and move into the clinical research corporations. The reason why they do this, as they say, as we interview them and we talk to them, they say, well, pandemic has completely flipped my life upside down. I'm looking for a job where I can have a 9 to 5 and I can close my laptop and spend the time with my family, because we had shortages of labor in my hospital, and so I ended up working 14, 20-hour days, and I can't do this anymore. When we talked to study coordinators, they also said that their paychecks were not really dependent on the number of hours they were making, and so that effort that they put in was not really financially benefiting them as much. So they're looking to make this switch, even understanding that working directly for a pharma company or a clinical research organization that organizes trials on behalf of the pharma companies, they will not be directly caring for patients, but they can see that meaning and their purpose in caring for patients indirectly through clinical trials and having a regulated hours. And that is something we've been hearing more from women than from our male candidates that join our types of companies. And of course, then it further impacts the access to healthcare, because if you have to wait to see your doctor or the line to see your doctor in certain countries gets longer because there's a shortage of labor, then that further impacts the outcomes and potential health outcomes.
Great, and that leads us to the next question, to Dr. OLAYINKA. What are the root causes driving the exodus of women from healthcare professionals? Is it solely burnout, or are there deeper systematic issues that need addressing?
Thank you so much. And I'll just pick up from where AGATA stopped, because it's really same. And I'll look at it from the perspective of sincerity and purpose. Why do we do what we do? So most healthcare workers take an oath to protect lives. And underpin that oath is the need to give all you can. And when you look at the situation in which you find yourself and you really can't give, infrastructure is not there to provide, again, the kind of care or outcome you're going to be hoping for. So on the long run, it brings in frustration that the life you want to save, you really can't save the life. Next is to look at Maslow's law of hierarchy. There are basic needs everyone requires. As a mother, I want the best for my children, and if where I'm staying can't provide the basic education, the basic type of housing, the basic type of, again, electricity, water, just basic necessity, I'll be looking to, again, it's going to be a shortfall on my side to say I can't even just provide the basic. Within the way you work as well, and for most women, in giving, you tend to forget who you are while you do some of these things. And for most women, you've had the issues around career growth, those opportunities to move next. 70% of the health workforce are women. And that 30% that are not women are always at the leadership position. We could say the pay gap, yes, maybe depending on where you work, there's a certain level of structure, maybe grade, whatever level, whatever you're entitled to this. But it goes beyond that, just like AGATA mentioned. One of the stakes is opportunities, and so when you're in the leadership position, you get some of those opportunities, come for a workshop, come for this, and you start advancing yourself. And those people that get those opportunities are not really the women doing the everyday work. So you could be earning same, maybe, but again, there's an opportunity cost that you don't get to because you're not in that leadership position, and those opportunities will always go by you. Or we have opportunity for just one person to join from the facility, is the most senior, and that person goes. That person is able to network, able to find the opportunities, know what the trends are, and starts to build himself up. And then you're left behind doing the extra. And it's also the fact that that unpaid work, so before you get out in the morning, you need to get the children prepped, the husband prepped, everybody prepped, and off you go. And you come back, in my context, you still need to look at homework, you still need to make sure that people get to bed on time, and then before you now, again, wind down. And the fact that majority of even the extra that you put in, because there's an undue pressure, even when you're in a leadership position, to still deliver. So you take even some extra hours at home and weekends, and you're trying to kind of like close the gap in things that you might have needed to leave behind. So there's a whole lot that makes, people looking for better opportunities, but really career advancement, again, the right pay, the right opportunity, the opportunity to provide the basic necessities of life for your family and yourself.
And when this person looking for opportunities immigrates to another country, what are the consequences for the healthcare system in your country?
Yeah, so there's been a whole lot of, for example, in my country, Nigeria, we've seen a whole lot of immigration in the last 5 years. It's alarming. And as our minister said about being, 70% going to the UK, if we decide to pull those people out, you can imagine what's going to happen to that system. While they're trying to find ways to address this immigration, the fact is welfare, healthcare workers' welfare, and the whole immigration really has put us backwards in terms of we're not on track for the SDG. It's less than 5 years. Our demographic health survey is coming out. I used to work solely on newborn. At that time, like 5 years ago, 2018, we had 39 out of 1,000 newborns dying. But now I'm hearing we had 42. So even maternal mortality has increased. So again, you've picked the best of the best. And when you look at the way the immigration goes, there are tests, there are things. So you've picked the best. And then we're left with. So we really need to look at how do we address this? How do we look at some kind of exchange learning, some kind of, again, if you're taking our people, then what are you giving us in return? But it has really, really dragged us back many years. And I do get why people need to go, but there's a disruption in the whole ecosystem, and we need to find a way to address it collectively. Managing the fact that we need to understand why people are doing this and to what extent can you provide that, what they are looking out for elsewhere, because then it's really, so I'll take a pause and say, okay, I try to work with so many healthcare workers during the COVID pandemic. And one thing was clear to me, we never see healthcare workers as human beings. We see them as channel of, again, take care of others. And nobody asks them, who's taking care of you? How are you feeling as a healthcare worker? In my training curriculum, I had to include that, again, healthcare workers well-being. And the first question I ask you is, who are you outside being a mother, a sister, a healthcare worker? Who exactly is OLAYINKA? That child, again, that was running up and down, do I still know myself? Do I still, again, have aspiration as a person? So you see most healthcare workers are not viewed, we just keep on looking at it. They need to take care of others. So how do we look at self-care, self-love for healthcare workers? And I wanted to start a campaign around stay alive to save life. Because if you are half full or you're not full at all, you can't give what you don't have. So most healthcare workers, again, their mental health, just that whole stress, not just the pandemic, but what you need to go through, losing a patient, somebody you've been, that's why I never did clinical medicine, because I just couldn't deal with the loss of, again, you spend hours, weeks on one person and then the person is gone for things that might not necessarily be, again, tangible to say you died. But really, how do we also help healthcare workers to see themselves as persons and remove that thing of take care of others? We need to start looking at healthcare workers and telling them, take care of yourself first. Self-love, self-care.
And let's all care for healthcare workers. Awesome, that was really powerful, thank you. So now, Dr. Susan, Women form the majority of the healthcare force but are underrepresented in leadership. What steps are needed to ensure more women ascend into leadership positions in health?
Thank you. Thank you, Gisela. Quite a good question. Allow me to highlight that for sure, statistics and numbers don't lie. Even if we disaggregate by regions, still majority of healthcare workers are women. But we always say there's nothing for us without us. In the leadership spheres, the women are still underrepresented. So what are we saying? That health is not only a fundamental right, but it's also we must take cognizance of gender equity in health, because this is the only way that we can ensure that representation of women is ensured. And why do I say this? There are many challenges that women do face, and I think my colleagues here have actually highlighted that. There's so many barriers before you get to work, unlike our men counterparts who will wake up and the next thing they find themselves in the office. But our JD is not different from their JD. So what we need to do, we need to focus on leadership. As women, if you're able to hold another woman's hand, you're doing a great service to the women folk as far as achieving SDGs 5 and 3 is concerned. It's important for us to also recognize the opportunities for change. What is it are you doing as a woman in leadership? Even the third, in Kenya we have the third gender rule, where if 70% are in leadership are men, at least 30% are women. But even then, with this provision, it has not worked quite well. We are still underrepresented, possibly because women are also not very ready to take up these opportunities. There are very many other things that come around and force women not to take up these opportunities for leadership. In Kenya and in Africa at large, and I believe also in the world, the majority of women will have to handle so many barriers before their leadership can actually be acknowledged. Allow me to highlight over and above mentorship and sponsorship programs. It's important for us to focus on leadership and training for women to be encouraged to take up these opportunities for leadership. Why do we need to train women? Because we have not been leaders before. So it is good for them to understand the sphere that they're coming into, and they are enough to get into that space that has actually been heavily men-led. So it's important for us to focus on leadership training and development. We need to create initiatives and workshops that encourage women to take up these positions. And that is not just enough, but giving them the role playing. If there's a woman, you're in leadership, how many others are you role playing for? How many are you holding hands? And how many are you training on how to do leadership? Because just leadership is not only what is written on the book. There's much more to that. Acceptability will only happen when we set gender quotas. And I think I mentioned about the third gender role, such that if 70 are men, then 30 are women. But even then, how many women are ready to take up these positions? So it's important for us to encourage each other and make sure that at least if you have a woman who is able and has the leadership characteristics, allow them and help them to take up that position. Allow me to give an example of myself. I became a leader, a chair of department within a public university in Kenya at the age of 28. And professors who were age of my grandfathers that time would actually look at me and ask, what does this young girl do? And in fact, that time, I was pregnant with my first one. So majority will look at me during Senate, that is the highest body that delivers examinations or passes the university rules. And they would look at me and wonder, what do I have to offer? And I did not wait to be given that seat at the table. I took the seat myself. And you know what? Thank you. And I realized by me taking that bold step, taking that position, and sitting at the table, I was able to save the women folk. Now I have very many women who have taken after me, and they always come and ask me, how can I get to the table and get to be heard? Of course, You don't just get to the table and be heard. You have to make your voice heard. Over and above that, I think it's important for us to advocate for policies, the policy change. Majority of countries have good policies, but implementation, I think, is something that is debatable. So when it comes to encouraging women to take up the positions, what policies are we bringing on board as countries so that then we're able to encourage these women to take up the positions?
Do you have any good example of successful policies that were implemented?
Thank you. A very good question. I think the World Health Organization has actually put together gender equity policy. And this gender equity policy, any country that has actually taken up on it, it has encouraged women to take up leadership by creating positions specifically for women. Case in point, in Kenya, we have the women rep position in leadership, where women are encouraged. It's only a seat or a position that is only eligible for women and not men. Because again, if you open a tab, then of course men will take it up for grabs. So, that's one of the major policy that comes to mind that will help women, and it has actually helped women to take up positions in leadership. Allow me to highlight diversity and inclusion committees that help women to take up such positions. And finally, what comes to work is flexible work policies. Why do we need to encourage flexible work policies? Because remember, as a woman, when you wake up, you have so many hurdles before you get to your desk. So how about some of these hurdles being handled in the office? Do we have flexible hours for breastfeeding women? It's a challenge. Do we have flexible hours for women who are able differently? It's a challenge. Even the facilities themselves, they are not provided for. In Kenya, I'll give also my example. Because I was a chair of department and I was breastfeeding, I encouraged and made sure that there was a policy within the university that is encouraging women to carry their children. And we were able to establish a creche for women who have children. In the past, majority of women in leadership, mostly in Africa, has been older women. For us who are already breastfeeding, or maybe you're getting your first child, because of course the biological clock and the professional clock are in total conflict. So what happens? Do I then have to wait until I'm 40, 50 to get a child because I'm in leadership? No. So I decided to drive change, and I was able to establish proper breastfeeding creche for mothers, and I was the first example. And my child breastfed for the 6 months that were needed to breastfeed. And today, I also traveled with my child to go and take up my master's and my PhD today, actually to US. So for us to drive change, we need to have more women who are talking about this and showing others the way, for sure. If you have not walked the way, you will not show the way. So if you have, please show the way. Thank you.
You didn't just build your seat at the table, but you did for a lot of people that came after you. That's brilliant. Thank you so much. So, Dr. ANNICK, the pandemic and other crises that we are going through at the moment exposed it and exacerbated risks to women in healthcare. How can we build more resilient, gender-sensitive healthcare systems post-pandemic and general crisis?
Thank you so much, Gisela. That's such a lovely question, and I think the answer is within everything my colleague said, and during the context of crisis. But allow me to ask the audience, raise your hand if you have been somehow mentally or psychologically affected during COVID-19. That's everyone, eh? Raise your hand if you are a health worker. Okay, we have a big group. So I think one of my colleagues, I think all of them even, said that women represent 70% of the health workforce. COVID-19 hit us, and we were obliged to find a way to get back to where we were before. We were obliged to find a way to get our people safe, our elderly safe, and well, everybody safe. And who did that? Who mainly did that? the healthcare workers, who are women at 70%. So if all of us, being healthcare workers or not, were affected mentally, can you imagine what it was for those healthcare workers to work in such a hard condition? For some of them, not be able to go home because you were fearing that you would transmit the disease to your father. For some of them, to lose your father or your grandfather because you bring back the disease at home. So kind of take a path behind it and reflect on what would have been your mental state if you were in that position. So COVID-19 really affected significantly women. We faced, for a lot of us, burnout. We faced crisis in families. We faced crisis in our marital status because of the work we were doing to save the humanity. But I will come back a bit on even crisis and pandemic. Until recently, until 2019, we thought, at least in the global north, that we were done with infectious disease. We were now fighting against chronic disease, but infectious disease is not really an issue. If you have a good system, you have a good healthcare, you have a good hygiene. But COVID-19 showed that we were not right about it. Infectious disease is still happening, and germs are getting even stronger. And we know now that AMR is the 10th threat for global health. And we can find ourselves back to the 1800s, where we didn't have really good tools to fight against germs. So did we really learn our lessons with COVID-19 on getting back together, global north, global south, men, women, and working against those kind of infectious disease? When we look at the recent crisis against the MPOX situation that is happening, do you feel like, raise your hand if you feel like we learned our lesson and that we are going to the right direction? I recently heard during that UNGA that one of the countries is even moving toward putting a quarantine at the airports because of MPOX. Some of the countries are closing their doors to conference because of MPOX. Is this the way we want to go forward with our works following COVID-19? If we do that, did we really learn from COVID-19 pandemics? I come from Burkina Faso. For those of you who don't know Burkina, it's a small country at the heart of West Africa, within the Sahel region. And Sahel region is really confronted. It's a group of 5 countries that share the Sahel desert. And the geographic is really affected by terrorist groups that attack those countries, particularly mine, which is now recognized as the second country in terms of security risk, but by the Security Index. Because of the number of people killed by the terrorist attack, and because of the number of people, the way that is affecting the country. Of course, when we have those kind of crises, what happens? The healthcare is affected. Why? Because you will have health facility closed. You will have a population that you used to master that move to another geographic, and that overwhelm the new geographic healthcare system. And do we even speak about gender in those kind of settings? Do we speak about even leadership? Because for them, it's about even subsistence. I know I'm an immunization person, I'm really passionate about immunization, but I know in one of the gatherings we had, people were looking at us and saying that we are not looking for vaccine, we are looking for food. When food is a problem, are you looking for healthcare? When healthcare is a problem, are you looking for gender? So we shouldn't, I was so amazed by all the panels that happened this morning. And I heard a lot, but I didn't hear about child, which is a neglected crisis that nobody can know about, where millions of families are displaced, are facing poverty, are facing hunger. So when we have those, we don't even speak about gender. But when you don't speak about gender, can you resolve those issues? You cannot. Who take care of the children in those the security affected contexts? 70% of the internal displaced population are women and their children. If you don't look at them through the gender lens, how can you resolve the issue? So we are in settings, there is crisis, policymakers are focusing their response on the crisis, they are forgetting gender, they are not putting gender lens to it, and so the solution is not responding conveniently to the people's needs. So during pandemic, during crisis, we do need to look at bringing, as Susan said, the leadership of women. We do need to bring policies that are gender focused in our conversation. During crisis, we need to look at our health workers, and OLAYINKA said it well. We need to look at their mental health. We need to take care of them. But to do that, we need systems that have that as policies, as norms, as SOPs. I heard since the beginning of ONGA, since my arrival here, that we all come every time to ONGA, to WGH, to all those conferences, we speak and we don't implement. I said yes, it's true, but at the same time, I also feel like we need that knowledge sharing. At ONGA, I learned about something that happened in Sierra Leone that is putting together a dashboard to look at pregnant women everywhere in the country. Simultaneously, I sent it to some of the policymakers that I know, and I said, look, Sierra Leone is doing this, and it's amazing. You should call the minister and see if it's feasible. So I don't think we are speaking and not doing, but I think we should do more. And to finish, I want to say that during crisis, one of the things that is forgotten and that you raised so well is the research and bringing women's perspective in the research. We developed drugs, as she said, without developing them for pregnant women, for infants, right? And after that, they are the most vulnerable population. We need to give them those drugs without having tested them, or those vaccines without having tested them on them. Now we are going to use Mpox vaccine without knowing how it functions on children. So that's a problem. So we need to build systems that have the ability to monitor the effect of all the intervention with the gender lens. We need surveillance system. For COVID, we didn't know if pregnant women were more affected or not, or at least in the global south, or if women were affected more than the other, because we didn't know, for each person, we didn't know the gender, or we didn't know the pregnancy status. So we need to put that in our surveillance system, in our healthcare system, and to make it able to respond conveniently during crisis. Thank you.
I would like to open the floor for questions, if anyone has anything to say.
Hi everyone. Hi, doctor. My name is Susie Mendeng, and I represent SIAP Africa, which is an NGO that go to Africa, all over Africa, and we build communities. Well, today I have a question. I'm not sure if I know your name, but I'm just going to say the question. Well, my question is about policies. You spoke about policies, but is there any policies that address the status of women during disasters? That's the first question. My second question is gonna go towards her, the African doctor. I don't know your name, I'm sorry. So my second question is about you. How would you compare the effect of this pandemic or the effect of COVID, the after effect of COVID on women to other crises that happen in Africa? I mean, Ebola, the seasonal flu, earthquake. So those are the two questions I have. I have another question, I'm sorry. Okay, my last question is about the other doctor that spoke about breastfeeding. She said she breastfeeded her child at the hospital throughout the pandemic, I think. So I'm gonna say this, I travel all over Africa. I've been to different hospitals. I'm in healthcare. So when you mention healthcare, I'm very concerned. So I have been to hospital and I have seen many hospitals in Africa don't even have a breastfeeding room. So my question to you is, were you allowed to breastfeed in the hospital because you're a doctor? Have you checked around you to see and make sure that someone who's just a nurse or a regular housekeeper or maybe a regular health professional can also be allowed to breastfeed and bring the child to the hospital? Do you have a lactation room in your hospital in Africa? That was my question. Thank you.
Who wants to?
Okay, can I start? Thank you, Susie. And yes, I was not breastfeeding in the hospital. I was breastfeeding in lactation rooms and creche that we created within the university where I work and where I started to work when I was really young, even before I got my first baby. And so, due to provision of such facilities for lactation, I was able to breastfeed my child for 6 months. They recommended at least 6 months before weaning. And that has actually set the stage for many other women that have come after me. And it has become a norm that within the universities, we do not only have older women, especially in leadership, we also have younger women who need support. So for provision of such facilities, then it has also ensured that nutritionally a child breastfeeds for the recommended 6 months before weaning. So I was able to do that. Of course, I want to agree with you that many facilities, especially the hospitals, that was the university, and I have also done that within Kenya. In health facilities, it could be a different game change altogether. However, it is always encouraged. It is not yet there, especially in many facilities, but when you're a woman leader, if you can make that change, it will then impact the women folk very well and ensures that we are running towards achieving the SDGs. You've asked about policies that are responsive to disasters. Yes, if I got you right, and yes, they are gender-responsive disaster risk reduction policies. When it comes to policies, and my view is this, majority of countries have very good regulations and policies. Implementation becomes the big elephant in the room. We are so very good in making these policies, but the implementation is the big elephant in the room. I want to speak for Kenya because that's what I'm very conversant with. I have also been engaged with making such policies, especially during COVID-19, and now we have MPOX here. Very good books, very good policies, but the implementation has always been the challenge. So as women leaders, the rallying call is that if you are a woman leader in your country and you are able to impact change, and especially in implementation of such policies, then that would be your contribution to change.
Can you please have an example, just one, because I'm very curious here. Just one example of those policies that you guys have.
In Kenya, yes, we have the gender-responsive disaster risk reduction policies. Gender-responsive disaster risk reduction policies, but it focuses on at least women and ensuring that the women, we have the gender analysis for number of women who are possibly working within a facility or within an institution. And that particular policy then helps to ensure that, yes, we know the numbers, we have disaggregated according to where they work and how well then are we able to assist them in ensuring that they deliver, especially as women leaders.
Thank you.
If I may add, I agree with you that there is a lot of policies, and if you just check, you will find some. One of the policies that struck me since a few days ago is Sierra Leone putting together the Child Marriage Act that allow. It might be nothing in this room, but it's really a step forward. And I know that there were so many voices against passing that bills that it was a huge success. And I think the Minister of Gender of Sierra Leone came on it. And what these bills allowed is now to enforce the fact that child marriage is forbidden in the country, and you can face jail time if you go for it. To come back to your question, comparing COVID-19 to all the other crises, the impact of women, I'm not sure we have data comparing between crises, but globally, because COVID-19 was a pandemic and have affected so much the economic system worldwide, it has affected more the economic of women in African setting. Why? Some of the first response things that we did for COVID-19 was putting people in quarantine. But you know that women are in the informal sector of the economic in Africa. They will go in the morning selling their stuff in the market and to feed all their families. So that's the first way they were affected. That is not even health related. The second way is they were affected is even having access to goods, because there were no boats coming from anywhere to anywhere. And the rare boats that you had was so expensive, so price in the market raised significantly. And then we put all those measures at health facility level. So they couldn't even take their child to the immunization, because we say that we need 50% at the immunization today, because we need to ensure social barriers that is respected. What happened? We lost 10 years of all the effort we did for immunization and for healthcare. So COVID-19 significantly affected all over the place women and even the overall population. But that doesn't mean that the other crises are affecting less. And I told you, if you take security issues, if you take flood, there is a flood happening, there is a cholera spreading. Of course, it affects women, it affects the population. And the security side is so, that one is so measurable. Like I have 2 million internal, we had 2 million internal displaced population out of 20 million in my country. And 70% were women and under 5 children. So you can directly see the impact of the crisis on the women. Now ending with the healthcare workforce, when there is an infectious disease, it affects them. But also when there is a crisis, it affects them, because as I said, if the system is not flexible enough, some of them are at home, while some other are overwhelmed with the number of people they are receiving. And to end with the leadership part, when there is crisis in the country, you will see that women at the leadership position start to decrease, and that's everywhere. It's not depending on the country. If it happened, I don't wish. If it happened in developed countries, you will see that women in the leadership position will start decreasing.
Okay, so I know we have our time. Just to mention the International Health Regulation, which all countries, the 195 member countries signed to, has a gender. Again, it wasn't included in the benchmark 2. A new benchmark 2 was released late 2023, but there's a benchmark action area on gender, which is related to all infectious disease hazards. So the International Health Regulation benchmark 2 has a gender component.
Thank you so much. Thank you all so much. Thank you everyone for coming. I think we have a lot to think about. We have many takeaways from this conversation, but especially how can we challenge the gender norms of the burden that women have on the unpaid work and always caring for everyone, who takes care of who is caring for everyone, right? And I just want to quickly say, give us all a call to action, because we have been here sharing this space and we're gonna go back home and we can bring this conversation to our dinner tables, to our business tables, and support our leaders and make sure that we hold our governments accountable in implementing the policies. If they're there saying they would have quotas, if they're there saying they want more women in positions of power, what are they doing? So it's up to us to go there and annoy them, and it's also up to men. So I think we should bring our allies here to start working too for us. And yeah, that's all for today. Thank you so much for coming.